All right, listen up, y'all. Can you hear me? All right. We're going to talk about fetal growth restriction. And I'm into preambles these days, okay? Like Buchholz, what's the preamble to the Constitution?
The people. We the people.
Richard, see why I had to do that?
I know.
Yeah,
I
okay.
agree.
All right. Okay, what's the preamble to fetal growth restriction?
Anything goes.
No.
There are no rules.
No, not quite. All right, what's the biggest problem that we face as obstetricians? See, I've lowered myself to y'all's level now. I said as obstetricians. No. Golly, I'm glad I showed up for this. All right, look, one of the biggest problems we face is gestational age, okay? If we don't have the right gestational age, we don't know how to manage the patient. All right, this is my preamble to fetal growth restriction. And let me show you what I'm talking about. Please let it work. Oh, there you go. For the longest time, we defined preterm birth by how much the baby weighed. This, I like history, so I went way back, 1959. Premature infant is one that weighs 2,500 grams, 5.5 pounds, or less at birth, regardless of the period of gestation. This is how we thought of preterm birth way back, okay? It's only recently, well, not so recent, but we now know preterm birth is anything before 37 weeks. Now, this caused some issues. I went back even further, 1947. McBurney, in such circumstances when the patient has been delivered of her baby within 1 or 2 weeks or even after the estimated date of parturition, it is extremely annoying to have a pediatrician insist that the baby is premature because it weighs only 4.5 or 5 pounds. Okay, so y'all get the flavor of my preamble to fetal growth restriction, okay? We know today that not only do we have to define preterm birth by 37 weeks by gestational age, we know today that there is this interface between gestational age and birth weight. So this is totally a dumb way to think of things. But, you know, do we have any pediatricians here? No, we don't. That's kind of how they look at life in general. Okay, now. Oh, we do.
My husband.
Voila!
But he didn't marry me, so.
I didn't mean that he was an idiot. But now that you brought it up, look who he married. All right, let's move forward. Okay, but you know, all things aren't the way it appears. This was a study done in 1964 looking at preterm birth. Oh, hit the right button. There we go. Premature birth weights less than 2,500 grams. That's how they were defining preterm birth. But this guy was rather clever. He must have been an obstetrician of sorts, because what he did is he took all of these infants and divided them up to 2 groups. He looked at them and said, wait a minute, this looks premature. Well, it doesn't look right. This one looks mature. So he divided it up into 2 groups based on how the baby looked at birth. And here's what he found. All right, here are the 2 groups, premature, mature. Remember, they all have birth weights less than 2,500 grams. Hey, y'all can come to the front if you'd like. That's okay. Oh, look it, they just started the rotation. Okay, but these are all babies that were born weighing less than 2,500 grams. This one looked premature, this one looked mature, and look at the differences in perinatal mortality based on birth weight. But it doesn't matter. For each birth weight, the ones that looked premature really were premature because they had a very high perinatal mortality compared to the ones that looked mature. Okay, so there's something here again between gestational age and birth weight. Now I was curious because I wanted to know, when did this transition take place between using birth weight as a measure of preterm birth and gestational age. So what I did is I went and I looked through the journal Pediatrics and identified all the papers that talked about preterm birth, and I saw how they defined prematurity. And here it is. They started out 1960. All of them talked about prematurity based on birth weight, like I just told you all. And then it kind of, as you can see, it kind of sloped downwards until after 1972. None of them defined prematurity in terms of birth weight. Come on, work. There you go. And here it is, gestational age. Right, let's see what I have here. There you go. In 1963, something happened in 1963, because in 1963, all of a sudden, preterm birth was defined in terms of gestational age. Well, you can kind of see the mixture, but something happened in 1963. And this is, I'm sorry.
That's how we got ultrasound.
No, not 1963, heavens. All right, this is what happened. This paper written by Lubchenko, 1963, published in the Journal of Pediatrics. She is a pediatrician, and she made a very astute observation that birth weight and gestational age are not synonymous, okay? So you have to consider both in looking at a pregnancy. And this is where we got the category now, small for gestational age. This is where it showed up. And it didn't show up clearly. If I look, I can see it, but somewhere in there, there's something. But any between 10th and 90th percentile, appropriate for gestational age. And there you go, small for gestational age, anything less than 10th percentile. All right, so this is where that concept showed up. This is my son. Oh, no. Oh, it's my wife. Isn't she wonderful? All right, she is, but I can't respond. All right, so this is where the whole idea of small for gestational age came up. All right, and this is my preamble to fetal growth restriction. Okay, we the people, whatever. All right, any questions so far? All right, let's see what the next slide is. All right, so now we're going to talk a little bit about defining fetal growth restriction. Now look, it's just all a whole series of circumstances which led to me giving this particular presentation today. Dr. Miller, Dr. Ruppel did an excellent job last week talking about a lot of this stuff, which is why I had to go through my slide and my stuff and throw out a lot of the stuff they've already talked about. Okay, one of the things they did talk about is the definition for fetal growth restriction. I just want to look at it a little bit differently because I just have a different outlook on things. Okay? Now, for our faculty who are wedded to practice bulletins, Dr. Barrow, raise your hand, who think the world revolves around ACOG, practice bulletins, and so on, let me just give you the standard definition. Birth weight, estimated fetal weight below the 10th percentile for gestational age. What about Mexican? Oh, jeez.
Don't mess with
No. Oh, you want to vote on Mexican? We're going to keep this apolitical. All right. Everybody knows this is a definition, okay? This is nothing but a statistical definition. That's, Dr. Wise, you are late. Would you like to get your lunch since you've interrupted everybody?
No, sir, I'll wait.
Okay, good decision. All right, this is nothing but a statistical definition for fetal growth restriction, okay? Number, average, a birth weight at a specific gestational age, 34 weeks, okay? This is a number of little kitties who have a certain weight, and it has that typical bell-shaped distribution. It's very easy just to lop off the lower 10th percentile and call that SGA. And that's all it is. It's a statistical definition. Let's see what happens when I hit this button. There you go. Statistical, that's all it is, statistical. And it's got a downside to it, okay? Because it's statistical, It's got a hodgepodge of different kinds of babies in there. It's a heterogeneous population. 80% of these kids, and Dr. Ruppel and Dr. Miller brought this out last week, 80% of these kids are just constitutionally small. 15% are what we call small because of uteroplacental insufficiency, and 5%, dog it. It was so nice. There you go. I hit the wrong button. And 5% are small because of chromosomal or infectious causes. And why is this important clinically? Well, it's real important clinically because if we intervene and the baby's just constitutionally small, then what we end up with is iatrogenic preterm birth. And that's not good. If we intervene and there's a chromosome or infectious cause, chances are that's not going to result in any improvement for the baby. So really what we're interested in is that 15% that are small because of uteroplacental insufficiency. And notice now, all of a sudden, you probably didn't notice it, I'm sleight of hand, but it used to be SGA, now it's FGR, okay? Now it's fetal growth restriction because when we speak of fetal growth restriction, we're talking about the pathologic condition secondary to uteroplacental insufficiency. Okay, so it's no longer SGA. I probably screwed up somewhere, but it's no longer SGA. All right? And this is the group that we're interested in. So somehow we have to separate this FGR, the growth restricted, from all the other stuff. Okay. I don't know what's next. Okay, estimated fetal weight below the 10th percentile is a statistical definition. It is arbitrary and not specific, and it contains both abnormal and normal babies in there. Arbitrary, not specific. Okay, detecting fetal growth restriction. Don't know what the next slide. Oh, there we go. Okay, a while back, Dr. Cooper made me do a little presentation on statistics. It wasn't my idea, it was hers. And we talked a lot about how prevalence affects positive and negative predictive values, right? Okay, well, a detection rate is a positive predictive value, okay? That's the way you look at it. So you ought to know back when I did this, wherever it was, that detection rate is going to be affected by prevalence. If you have a population consisted of a low risk population, then the predictive value or the detection rate's low, 23%. And if you have a high risk population, the detection rate is high, 58%. So you have to understand your patient population when you do these tests. I mean, what's the probability that it's a false positive, true negative, et cetera, et cetera. Okay, everybody with me? This was a study done back a while, 2005, looking at the accuracy of ultrasound in identifying birth weights. Okay? Amrine's not here, but I'm always asking what's the estimate? Oh, it's 7.5 pounds by Leopold. You know, that seems to be the going thing. But what's the accuracy in predicting birth weight with ultrasound? This is a study, what it did is it assimilated a large number of studies between 1973 and 2003 looking at the proportion of estimated fetal weights that are within 10% of the actual birth weight. And you can see all the scatter in this data, and if you take the average, 60% or so of the estimated fetal weights are really within 10% of the actual birth weight. Another way to say this is 40% of the time you're going to miss the actual birth weight by more than 10%. So when the mama comes back and says, you told me my baby was going to be 7.5 pounds, and it's really 10 or 12 pounds, well, what can you expect? But this is important that you all know this, that the ability to identify a growth-restricted baby is only as good as the ability to estimate fetal weight, and you can see right here that we're off most of the time, or a lot of the time. Of course.
How soon after birth, like how close was the ultrasound?
Usually what he did is he picked studies within 10 to 14 days. So yeah, within 2 weeks. Okay. So how do we predict birth weight below the 10th percentile? And we ought to know this stuff, okay? I mean, there's only a few ways we can predict birth weight below the 10th percentile. The obvious is right there, based on the size of the baby, abdominal circumference, estimated fetal weight. But there are other approaches to this. For example, a lot of people think there's a correlation between how much amniotic fluid there is and birth weight. So use oligohydramnios as a way to predict birth weights less than the 10th percentile. Or the S/D ratio. A lot of people try that. These are the physiology approach to identifying a baby with a birth weight less than the 10th percentile, estimated birth weight. Okay. So we put all this together and, well, let me give you the composite. So based on this limited amount of numbers that I have there, you can predict a birth weight less than the 10th percentile using some combination of these things, maybe 75% of the time. You can take a different approach. You can do serial measurements. A, B, 2 weeks between. This is my preferred approach to identifying a growth-restricted baby. If I get a baby that's measuring, let's say, below the 10th percentile estimated fetal weight, or the abdominal circumference is less than the 10th percentile, what I will do is I will see the patient back and measure estimated fetal weights and abdominal circumference again 2 weeks later. Notice it says here greater than or equal to 2 weeks. Some people use 3 weeks. I personally prefer 2 weeks. Now there's a problem. Error compounded when derived growth estimate is used. All right, Buchholz, help me with that. What does that mean? You're going to have to stay awake today.
Bring more factors in, your margin of error gets higher.
Okay, so more factors meaning?
Higher margin of error.
No, but be more specific.
So you're using those measurements in those average measurements to calculate an average.
Very good. Okay, does everybody see what he's talking about? Well, we estimate fetal weight using AC, BPD, femoral, all that stuff. But each of those parameters has an error associated with it. So when you throw it into the equation to calculate an estimated fetal weight, the error is compounded. All right? And this is why, me personally, I prefer the AC. Again, we're talking about serial measurements. And what I look for is the AC is more than a change in the abdominal circumference is 10 millimeters or more over a 14-day interval. Now, I need to be honest here. Time for disclosure. That's based on one study that was done in 1980-something, all right? So there's not a whole lot of data on this. But that's my approach to managing growth restriction. Prefer AC. Okay, there you go. All right, and let me show you how this works. Abdominal circumference, gestational age, boom. There's a measurement. Voila, I see the patient, I measure the AC, have her come back 2 weeks later, change in AC 30 millimeters over a 14-day period, but you don't even need rocket science here to do that. Look, you can see how it parallels the growth curve. So right away, you know the baby's growing normally. It's just small, so it's probably SGA. I don't know if I had that up there or not. Yeah, there you go. And I expect normal testing. Would I do antenatal testing on this? Yeah, because nothing's absolute, okay? But I expect everything to be normal. Here is another one. Boom, there's a measurement. Now I have this. And right away you can see how that deviates from the growth curve. The change in AC is only 4 millimeters over a 14-day period. Fetal growth restriction, expect abnormal testing. All right. See, I just showed you all you needed to know to do a fellowship in maternal fetal medicine. Right there. Okay. There are so many studies out there looking at ultrasound parameters for predicting fetal growth restriction. There are tons of them. And, you know, I got tired of listing them. I mean, geez, it's a lot of work to write all that out. And there's some of them. All right. So, what we ought to glean from this little bit is what? Definition for fetal growth restriction. We never really talked about it. I mean, some people use estimated fetal weight below the 10th percentile. Some people use an abdominal circumference less than the 10th percentile. Just depends on how you want to define fetal growth restriction. The detection rate depends on what ultrasound parameter you use. It depends on the population you're studying, remember. Depends on prevalence. Depends on what equation you're using for estimated fetal weight. And it depends on the sonographer. So there are a lot of variables here that affect your ability to detect fetal growth restriction. And I didn't put it up there, but it's not up there. Knowing gestational age is critical. All right, critical. All right, greatest detection rates achieved with the estimated fetal weight below the 10th percentile. And now here you see AC less than the 5th percentile. Studies show that AC less than 10% really is not that important. It's when the AC gets really small where all of a sudden all the morbidity and mortality shows up. Okay, expect at best, estimated fetal weight within 10. All right, we've already talked about that. Accurate diagnosis of fetal growth restriction remains problematic. It's really, really hard to do. You can see this, y'all, through your experience. Every baby's growth restricted. I mean, really think about it. When you see them in clinic, virtually everybody's small. All right? All right, cardiovascular response to hypoxemia is either Dr. Ruppel or Dr. Miller broached this subject last week, and I'm just going to kind of expand on it a bit, just because I like to talk about this. All right, cardiovascular response to hypoxemia, acidemia in the fetal lamb. This is a classic study by Kahn published in 1974. Dr. Buchholz, it seems like you're my go-to guy today. Just in general words, what's the cardiovascular response to hypoxemia?
CNS sparing, so it tries to push blood to the heart and the brain and then decreases blood flow in other areas.
Okay. And we know all of that from this one particular study, okay? This was an animal study done in fetal lamb. Here are the various organs: kidney, carcass, heart, brain, adrenal. Anything below 0, decrease. Anything above 0, increase. All right, kidneys. Decreased perfusion to the kidneys leads to oligohydramnios. Decreased perfusion to the carcass. This is where we get fetal growth restriction, okay? Increased blood flow to the brain. This is the brain sparing effect, okay? So this is kind of it summarized nicely. But notice also increased blood flow to the heart and to the adrenal glands. The adrenal glands is one of the more critical organs in the fetus. All right. Doppler flow studies, umbilical artery, middle cerebral artery, and the venous circulation. Ductus venosus, umbilical vein. I don't know who did the ultrasound with me whenever it was. I'm sorry? Oh. But I tried to show him the umbilical vein as well. And Dr. Harris, I think I might even show her. Maybe not. Umbilical artery assesses placental vascular resistance, middle cerebral artery, blood flow distribution, and the venous circulation, cardiac function. And that's kind of the way you look at this thing. And there it is, umbilical artery. Boom, 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 boom. Y'all have seen this before, right? Buchholz on the Discovery Channel. All right. And I think Dr. Briette pointed this out last week. See, there's a systole and a diastole, And there it is, systole and diastole, boom, boom. And then the ratio of the two is the S/D ratio. But notice that the blood flow is continuous during diastole. Now, here we have an increase in placental vascular resistance. Now it looks different, all right? Absent diastolic flow, so there's no flow in there, all right? Now, there's a way big increase in placental vascular resistance. And here you have, boom, really increased. This is a reverse diastolic flow. Sometimes that's hidden because of the vein. You end up interrogating the umbilical vein as well. But that's what it typically looks like.
Is it true in different parts of the urine when you're in the cord, if you're measuring different areas?
It makes a big difference.
You'll see.
Yeah, really what you ought to do is sample 3 or 4 regions somewhere midway in the cord, but the practicality of it, that's difficult. I'm sorry?
Is there a why that there's going to be different?
Well, think about it. You're closer, well, it's not that so much. You're closer to the fetal heart, and then you're closer to the placenta, so you really need to separate the two. It's kind of like math,
Yeah,
Cooper.
that's why I was asking.
Yeah, all right. All right, perinatal mortality according to umbilical artery Doppler flow. If you just look, well, look, this is normal, increased S/D, absent end-diastolic flow, reverse end-diastolic flow. The first bit down here was done by Karsdorp in a big study, and what he did, he showed elevated S/D ratios correlated with perinatal mortality. And then this was expanded on by this group here in 1996. But what can you conclude from this? Perinatal mortality, gestational age, what can you conclude from the book holes? Correct. As the placental vascular resistance increases, the perinatal mortality increases accordingly. So there is a definite relationship between the umbilical artery flow pattern and perinatal mortality. So that's a good thing to know. Hypoxemia, acidemia induces, this is just kind of a summary, which we've already said. Okay, I just want to reiterate this part. Association between Doppler flow pattern and the umbilical artery and perinatal outcome. I think that's a pretty good take-home message right there. So the real question is, how do you manage these? And this is not easy. If the baby's term, it's pretty easy, okay? If the baby's premature, it becomes a problem. And the reason I say that is we're always trying to balance the risks of prematurity with the risks of continuing the pregnancy. The risk of prematurity being neonatal morbidity and mortality, the risk of continuing the pregnancy being stillbirth. So that's kind of what we do, is balance that. That's why we do all this antenatal testing, trying to prolong the pregnancy to minimize this and hopefully avoid a stillbirth. So this is the most critical aspect of antenatal management. How do you balance this risk of prematurity, risk of continuing the pregnancy? A lot of what we do is pretty straightforward stuff, okay? Biophysical profile. I don't need to tell you all what's in that, but I might want to mention this. These guys up here, NST, breathing movement, what else I got up there? Tone, general body movements. These are acute measures of fetal condition. And amniotic fluid volume is a chronic measure. Now, what is it we're trying to measure? I know I asked Dr. Ruppel this a few weeks ago. When we do a biophysical profile, what is it we're trying to determine? Let Buchholz answer. Dr. Buchholz. Asphyxiation? Okay. Hypoxemia, acidemia. Those are the things we're looking at when we're doing fetal biophysical profiles. So what does that tell you right away as far as managing the diabetic pregnancy? Help me out. Buchholz.
Higher rate of complications. You want to start these steps in early.
Okay. Let me pick on Dr. Morgan. He looks too comfortable. Okay, so the biophysical profile is assessing for what?
It's assessing for fetal well-being or
Based on, I just mentioned that, maybe not clearly enough. Get rid of asphyxia, hypoxemia, acidemia. So the question was, what does that say about using a biophysical profile in diabetic pregnancies? Think about it. I'm going to ask you in 2 minutes. Maybe not quite 2 minutes. You might get a hint from this, okay? Relationship between individual biophysical activities and cord pH. This was a study done by Tony Vinceleos way back, 1991. What he did, he probably didn't do it. He probably got one of his fellows to do it. But stick a needle into the umbilical cord, sample the umbilical cord, and determine what the pH is right after they did a biophysical profile. All right, and here are the elements. Reactive NST or fetal breathing movement. Non-reactive NST, no fetal breathing movement, no general body movements, no fetal tone. This is umbilical artery cord pH, and when you go from left to right, we're talking about worsening acidemia. And what you can see, if you have a reactive NST or you have fetal breathing movement present, cord pH is pretty good. If the NST is not reactive, cord pH still isn't bad. And if you go one step further, not reactive and no fetal breathing movements, the cord pH is still not bad. If you go then one step further, add to that no fetal body movements, the cord pH drops under 7.1. If you go one step further, no fetal tone, the pH approaches 7. Okay? This is why when y'all call me and tell me the biophysical profile is 6, I generally ask, what's missing? If you tell me, oh, the heart rate's reactive, the baby's breathing, but there's no movement, no tone, okay, so what? Just repeat it in a couple of hours and see what happens. Most likely it's a sleep state. But if you tell me that the heart rate's not reactive, that the baby hasn't been breathing, to me that means a whole lot of different things. That means the baby's probably compromised and we're heading down this direction here. All right, let's see what the next slide is. Ah, there we go. Just what I just said. I didn't realize I had the arrow, but it looked nice. Okay. It doesn't show up as nice. I could turn the lights out, but Buchholz will doze off. All right, these are early changes. The loss of reactivity, the loss of fetal breathing, these are early changes in the pathology. In other words, initial insult of hypoxemia, okay, not too bad, non-reactive NST, no fetal breathing movement, but if that stays longer, if it's not corrected, then you turn into late changes, no body movement, no fetal tone. All right, everybody got the idea here? All right, Dr. Morgan, tell me. Tell me. How y'all doing up here? I appreciate y'all showing up. Thank you. Does anybody want to answer that question? Does anybody read my mind? No, I'm not. Okay, look. We do it for hypertensive pregnancies. We do it for diabetic pregnancies. What's the difference between A and B? Oh, help me. The chances are much greater that the hypertensive pregnancy, the baby's hypoxic, okay, because of uterine placental insufficiency. Diabetic pregnancies don't get that way. That's why doing a biophysical profile is not a whole lot of help in managing a diabetic pregnancy. Do we do it? Sure we do, because there's not anything else that helps us. All right? Oh, Lord. I'm so grateful our students are here. Thank you all so much.
If they have vascular disease, they're not at risk for that.
No, yeah, of course, if they have vascular disease. Yeah. Dr. Morgan, you got that? Okay. Did y'all like your lunch? You get to eat? Thanks. All right, the department paid for that, by the way. You're not going to get that with other departments. Remember that when you evaluate our program. Bruno, how'd I do? That's good? All right. All right, temporal changes in the biophysical profile. Oh, this is so important, because how in the world do you manage these pregnancies? This is what it's all about, okay? Abnormal, this is the percent of something that's abnormal. And if I'm looking at NST, that's the percent of babies that have an abnormal NST. This is days before delivery. 7 days, that's a week before delivery. Here they delivered the pregnancy, the baby, the mama, whatever, if the biophysical profile was less than 6, okay? So that's the end point for delivery right there. Now, let's look at this. Way back here, a week earlier, the NST was abnormal in 80% of the pregnancies. Fetal breathing movements was abnormal in 20% of the pregnancies. But look, general body movements, fetal tone was totally normal in all the pregnancies. And it's only, hit the right buttons, it's only as you approach delivery where the tone and general body movements become abnormal, okay? So you can look at this. The color's not good, but you can look at this. NST, fetal breathing movements, these are early changes. Just like I said a slide or two back. Early changes in the biophysical profile. And these guys here, tone and general body movement, these are late changes. All right? And they usually don't occur until it's time to deliver the baby. All right, so I like to consider the individual components of a biophysical profile. To me, the total number is not that particularly helpful, but I don't ignore it. There are early and late changes in a biophysical profile. Absent fetal tone, absent general body movements is a late change, and by then probably the baby's already compromised. But we don't have anything better, okay? So let's keep that in mind. And then, given all this, this helps me lead into the next part. Use the Doppler to help kind of fine-tune our management some, okay? All right. Temporal change in Doppler flow patterns, increased STD, this is the middle cerebral artery, absent end-diastolic flow, ductus venosus, reverse end-diastolic, and another ductus venosus thing. Abnormal percent, days before delivery. Here, delivery was done for abnormal fetal heart rate pattern. But you can see right away, an increased STD ratio is a very early change. Brain sparing, redistribution of blood flow, early change. Even absent end-diastolic flow is an early change. I mean, these take place a couple of weeks before the fetal heart rate pattern becomes abnormal. And then all that other stuff is late. So we can kind of, whatever that arrow is doing. And then we delivered. All right. Early, late. So when we have reverse end-diastolic flow, that's kind of a late change. And it kind of suggests, well, the baby's probably not doing so good. Okay? So what we like to think of it as, there is a progression in abnormal Doppler flow patterns. They said this last week. I remember Dr. Ruppel saying that. Umbilical artery changes first, middle cerebral artery changes, and then that other one up there, the venous circulation changes. All right? So, first there's an increase in placental vascular resistance, then there's a blood flow, redistribution, and then cardiac dysfunction. That's kind of the way we look at this. And we'd like to think this is how life is. It's real simple. You go from the umbilical artery, the middle cerebral artery, to the venous system. Okay, it's not exactly as easy as it looks. This was a study published 2013. Predictable progressive Doppler deterioration. Does it really exist? What they did is they took over 1,100 pregnancies where they had measured, these are growth-restricted babies, where they had measured all these Doppler parameters. And what they found, in contrast to previous reports, we have demonstrated multiple patterns of Doppler deterioration, not the pattern umbilical artery, MCA, ductus venosus. All kinds of other patterns, which calls into question the usefulness of multi-vessel Doppler assessment to inform frequency of surveillance and timing of delivery of fetal growth restricted fetuses. Okay, so I didn't want to give you the impression that everything is so nice and neat, because it's not. It's not that easy. Abnormal Doppler flow pattern precedes abnormal fetal heart rate and or biophysical profile. By 2 weeks, increased S to D. 1 week, absent end-diastolic flow. 3 days, reverse end-diastolic flow. Notice there's nothing in here about MCA, nothing in here about ductus venosus. This is all the simple stuff, okay? The umbilical artery stuff. The important point here is that once you start getting these abnormal, especially reverse end-diastolic flow, you got a problem. Evaluation diet. Okay, so what good is all this? Oh, Lord, how good is all this? This is how we manage these pregnancies. When you start getting these abnormal Doppler flow patterns, you got to start deciding, do I need to give the patient steroids? How often should I do fetal testing? Sometimes you have to do it every day. Do you need to put them in the hospital? Do you need to deliver the baby? This is what I'm talking about by using the Doppler flow stuff to maybe start fine-tuning the management of the pregnancy.
Do you hospitalize primarily for closer monitoring?
Yeah.
Because there's nothing valid to being in the hospital.
No. Okay, cardiovascular status predicts perinatal outcome. This was the study 2004. These are the, I don't know, count them, 6, 7 different studies. This is a composite of all of these studies looking at outcome. Now, the way I have it set up, it's moving from umbilical artery to the venous system, worsening cardiovascular status. Now, I got a bunch of colors and stuff up there, and there's a reason. The first one, the blue, is gestational age. And I got little arrows that come down, and you can see as the cardiovascular status worsens, these babies end up being delivered earlier. Gestational age earlier. This is birth weight less than the 3rd percentile. And you can see as cardiovascular status worsens, the frequency of really small babies increases. And finally, stillbirth, IUFD. As cardiovascular status worsens, then the chance of a stillbirth increases. All right, pretty simple stuff here. This is good. Now, I don't want to mislead you all in thinking that all that's important is the umbilical artery, because that's not true. So what I did is I just kind of threw out here 2 studies looking at the brain sparing effect. This first one, 2011, brain sparing and neurobehavioral outcomes. Abnormal MCA Doppler findings are predictive of neurobehavioral impairment among preterm babies with fetal growth restriction. The other, the role of brain sparing, results of the multi-center Porto study. Brain sparing is significantly associated with an adverse perinatal outcome in fetal growth restriction. So I don't want to leave you with the idea that it's not important, it is. But practically speaking, the umbilical artery is really the key. All right, cardiovascular deterioration occurs earlier. Hold on a second. Cardiovascular, just like you deliver the baby earlier. As the cardiovascular, you have a tendency to deliver preterm. There's a greater frequency of severe fetal growth restriction and higher perinatal morbidity and mortality. Okay. When do we intervene? Ugh. All right, this is I shared this, I guess, with Dr. Miller and Dr. Ruppel. This was a study done 2007, survival, neonatal survival as a function of gestational age. This was a study where they looked fetal heart rate, BBB, Doppler parameters. These were used in the management of these pregnancies. And what they did is they looked at gestational age, birth weight. They used, multiple regression and all that stuff to sort through what was the important parameter that predicts neonatal survival. If the baby is before 27 weeks, by far gestational age dominated neonatal survival. It had nothing to do with the Dopplers, the biophysical profiles, the NSTs, none of that. It was dominated by gestational age. After 27 weeks, then all of a sudden ductus venosus became important, and this is for neonatal survival. If you look at intact neonatal survival, up to 29 weeks, it was dominated by gestational age. What did I do? After 29 weeks, then the ductus venosus became important. I hope I have a take-home message here. What in the world? Okay. Venous circulation, we can skip that. All right, so before 27 weeks, the impact of gestational age is so important that no fetal testing modality provides sufficient stratification of risk. And that's why you see me dragging my feet on the labor unit. Oh, look at D-cell. 26 weeks? No. I need to see a lot more than a D-cell. After 27 weeks, then there's the ductus venosus. Don't do that at home, though. Don't try to measure that at home. Can't be done. All right, abnormal ductus venosus is a late and infrequent finding. It doesn't occur often. And when it happens, it's late because the fetus is already compromised, usually severely compromised, and it's only seen in less than 30% of babies before a biophysical profile less than 6 to 10 is reached. Okay. All right, I think I've tortured you all enough. Let me this stuff we've already done. I can do this quick. All right. This all goes back to early changes, late changes. Early changes, umbilical artery, middle cerebral artery, about 3 weeks prior to delivery. Late change, ductus venosus, and there's another parameter, aortic isthmus, 2 weeks before. All right. When do we intervene? I haven't told you when do we intervene, and you want to know why? These are 2 randomized studies looking at the use of Doppler in managing these pregnancies, these growth-restricted pregnancies. I like the cute little names, GRIT, Growth Restriction Intervention Trial, Truffle, oh, smooth, trial of randomized umbilical and fetal flow in Europe. This is something that Dr. Gwynn would make up, Truffle. I'm telling you. It reminds her of crafting and all that. Okay, look. These are 2 randomized studies, and none of these really gave a whole lot of help to obstetricians in managing these pregnancies, and that's why I have a comment there, not much help. All right? So that's kind of how, when do we intervene? It's called clinical judgment. Okay, gestational age and birth weight overwhelm the neonate and infant at outcomes less than 27 weeks. Active management should focus on prolonging the pregnancy for gestational ages between 27 and 34 weeks. I think I have something there. Doppler, biophysical profile, NST. These are the things we use to try to prolong the pregnancy. Have a low threshold for delivery after 34 weeks. Okay, that's pretty straightforward. There you go. Final general comment, individualized care. That's so important. And I don't know if I've got another slide. I do. Oh, final comment. Geez, not just a comment, but a final one. Timing delivery of the growth-restricted preterm fetus is the most critical management decision. All right, I'm done. Dr. Koo, thank you for joining us. You have some comments on gestational age? I hope I emphasized it enough.
In terms of survival, right? we are certainly as good, if not a little better than what you showed. So after 30 weeks, for practical purposes, depending on you guys, that if you're going in and out, we have to go. But certainly 34 weeks.
Okay. Does anybody have any, Dr. Buchholz, what is your question?